Certainly. So Visionary MS is a phase 2 placebo-controlled trial of 2 doses of CNM-Au8, a 15 milligram dose and a 30 milligram dose versus placebo. Now, CNM-Au8 is taken once daily orally. Generally, we ask patients to take it first thing in the morning on an empty stomach and then not to eat for 30 minutes afterwards, just to make sure that the golden nanocrystals are absorbed. It is a study in stable relapsing patients. So typically in a phase 2 study in relapsing MS, for all of the currently available disease-modifying therapies, as a community, what we would typically do would be to take patients who have active relapses and you put them on drug X versus placebo or versus a less potent drug, and the relapses go away. And the gadolinium-enhancing lesions go away, and maybe even have some effect on atrophy. So that's generally what phase 2 studies, how generally in relapsing patients are designed. Now, this is very different. We're taking patients who are already on disease-modifying therapy, and they have to be stable. They cannot be having relapses. If you're having relapses, you can't get in the trial. And you have to have evidence of chronic damage to your nervous system. So that evidence is you have to have evidence of a loss of vision based on low contrast letter acuity in order to get into the study. Now, you can't have had acute optic neuritis within the previous 6 months, and you can't have had a relapse within the previous 3 months before getting into the study. So we're looking at patients who are on therapy, who have chronic visual impairment, and then we're putting them on CNM-Au8 in addition to their standard of care, or we're putting them on placebo in addition to their standard of care, and we're looking for neurological improvement. So it's quite a different phase 2 study than is typically done in relapsing patients. Well, of course, we have not unblinded the study yet. And of course, unfortunately, because of the pandemic, most studies with relapsing patients, even MS patients, have been put on hold for the past year. We have not been able to enroll significant numbers of patients because patients are immunocompromised on their disease-modifying therapies, and both patients and clinicians are reluctant to bring them into academic centers to be evaluated. So, as with most MS studies, our study has essentially been on hold for the past year. So, although we were a third of the way enrolled before the pandemic hit, so those patients have continued through the study. Now, the primary endpoint is change in low contrast letter acuity from baseline to week 24, but we're collecting all the modified MSFC subscales, which consist of, the modified multiple sclerosis functional composite. The MSFC consists of low contrast letter acuity, symbol-digit modalities test, a test of working memory, the 9-hole peg test, both the dominant and undominant hands, and then the time 25. Those 4 tests together make up the modified MSFC. So we're collecting all of the modified MSFC subscales, but the primary endpoint is change in low contrast letter acuity. Now, the way the study is designed, all patients remain in the double-blind placebo-controlled portion of the study through week 48 until the last patient finishes week 24. So we'll have 48-week double-blind data for almost all the patients. But of course, we have not unblinded the study yet. So what we actually presented was kind of a novel way of looking at blinded data. So, we said to ourselves, well, how can we have a comparator group? And we don't really, without unblinding the study, you don't really have a comparator group. So what we did was we actually took the patients who had the lowest EDSS scores at baseline. So that subpopulation of patients who had an EDSS of 1.5 or less, and we took their scores at baseline and used that to compare the progress of the group over time. So we just took the entire population, we compared them to the most mildly affected baseline population, and said, how does the overall population throughout the study, how do they compare to the most mildly affected population at baseline? And what we found was that for a symbol-digit modalities test and for the low contrast letter acuity, in fact, the population as a whole went from being, of course, poorer than the least affected population to actually being better than the least affected population. And in terms of 25-foot time, 25-foot walk, and the 9-hole peg test, they went for half a standard deviation worse than the most mildly affected population to actually being almost the same as the mildly affected population by week 36. So what we're seeing is, in general, the population as a whole is improving over time. Now, of course, there could be we're hopeful that that's a drug effect, but that could be multiple things. It could be placebo response. Of course, we know that placebo works in neuroscience. It could be learning effects. It could be other things. But we're very, very encouraged by the fact that the population as a whole seems to be improving throughout the course of the study, and substantially improving, frankly.